Yes, you can start, Vajina.
Good evening, everyone. A warm welcome to the ISA National PG online class session. Myself, Dr. Wajiha, working as a senior resident in Department of Anesthesiology in GB Pant Hospital, Delhi. I will be one of the screen coordinators for today's session. The topic for today is neurological monitoring in anesthesia and a case presentation on role of neurological monitoring in a case of adolescent idiopathic scoliosis posted for corrective repair surgery. Intraoperative neurophysiological monitoring has been utilized in attempts to minimize the neurological morbidity from associated with operative manipulations. Its importance lies not only in diagnosing injury, but also in creating a window of opportunity to salvage the neural tissues at risk before the damage becomes irreversible. So before moving into the session, let's invoke the blessings of Goddess Saraswati in the form of Saraswati Vandana. Now I would like to invite Dr. Sukhminder Bajwa Sir, Honorary Secretary, ISA National, to speak a few words. Over to you, sir.
Thank you, Dr. Vajiha. On the outset, I say Eid Mubarak to everyone. Today is Eid. So, starting with the topic today is a very, very difficult, complicated, simple. You can term anything to this topic. The neuro monitoring is right from the basics, from the periphery to the advanced centers in the metros. You have got all type of gadgets available for neuro monitoring, right from your basic clinical skills. With I think when we started our career at that time, the most striking was the BIS, which came into the picture. Then the evoked potentials also marking their presence, and now with the specialized neuro monitoring standards have evolved over the time into the many advanced gadgets. But ultimately, it's the brain, how the brain behaves during these type of cases. That's the most important. Idea is to have a neuroprotection with the help of a neuro monitoring so that we go ahead with the surgery in the most smooth manner so that the patient should not have any neuromorbidity post-operative in the, whether it's a neuro case itself or maybe some major case wherever the neuro monitoring is very essential. I think we have got a very good team today. Dr. Srinivasa and his team, they are the justice to this topic. So without wasting time, I hand over it to Dr. Vajiha to start the proceeding from here.
Thank you, sir. Now I would like to request Dr. Ishita, my co-screen coordinator, to welcome and introduce our esteemed faculty members and to carry the session forward. Over to you, Dr. Ishita.
Good evening, everyone. Hi. I would like to introduce our moderators for the class today. I would like to introduce our first moderator, Dr. V.Y. Srinivas sir. He is the professor and head of department at the Mysore Medical College, Mysore, RGUHS. Sir has an esteemed teaching experience of about 24 years. He keeps special interests in research as well as yoga. He has given lectures in national, state, South Zone conferences, a lot of paper presentations. He has over 32 publications as well. He has also achieved a gold medalist award in anesthesia at the RGUHS. Our second moderator for the class will be Dr. Vivek Nayak sir. Sir is assistant professor at the Mysore Medical College and Research Institute, RGUHS. Sir has an esteemed teaching experience of 9 years. Sir keeps special interests in anesthesia workstation designs, neuro anesthesia. Sir has been giving guest lectures at various universities for a very long time now. Sir has esteemed publications, about 4 of them so far. With this, I would like to welcome everybody to the class. We'll proceed with the class. I also want to share some rules before we can start the class. The rules will be, everybody will be muted during the session in this class. Anybody who has questions can type in the chat box here in our class. All of you are also requested to keep your videos off during the class. With this, I would like to thank everybody and hand over the mic to the moderators so they can begin with the class.
Good evening, everyone. Respected ISA Secretary Dr. Bajwa sir, Dr. Madhuri madam, and all ISA members, postgraduates, I welcome all of you to today's class. Our final year postgraduates, one Dr. Sneha Abraham and another final year postgraduate, Dr. Vaishnavi SG. They are going to present the case, role of neurological monitoring in a case of adolescent idiopathic scoliosis posted for corrective repair surgery. Over to our presenters.
Good evening, everyone. Today we'll be discussing about the role of neurological monitoring in a case of adolescent idiopathic scoliosis posted for corrective repair surgery. Our patient is an 18-year-old male student who's a resident of Mysore who belonged to a lower middle class family. He came with chief complaints of deformity in the back since 5 years and dyspnea on exertion since 2 years. Patient was apparently all right 5 years back when he started noticing deformity in the back at the age of 13 years, which was gradually progressive in nature and increased in 2 years, which was associated with history of restricted back movements, history of difficulty in lying down in lateral position, and history of difficulty in walking. He also complained of dyspnea on exertion since 2 years, which was gradually progressive in nature, and he was now breathless on walking uphill, which was relieved on taking rest, and there was no postural variation. There was no history of fever, cough, sputum production, orthopnea or paroxysmal nocturnal dyspnea, chest pain, palpitation, swelling of legs, or syncope. He has no history of back pain, weakness of limbs, numbness of limbs, loss of balance, pain and deformity in small joints. There was no history of trauma to the spine or radiation exposure. There was no history of restricted neck movements, difficulty in having food, abdominal pain, urinary or fecal incontinence, history of decreased urine output. His exercise tolerance was more than 4 metabolic equivalents. Past history, he has no history of other congenital deformities or defects. He was not a known case of diabetes mellitus, hypertension, bronchial asthma, pulmonary tuberculosis, epilepsy, cardiac or thyroid disorder. There was no history of previous surgeries, blood transfusions, ICU admissions, or drug allergies. There was no similar history in the family, no history of congenital anomalies in the family, or history of chronic illnesses. His drug history was not significant.
Is it a familial disorder, scoliosis?
So it could be familial, sir.
Okay. Why he has got dyspnea?
Sir, as the severity of the scoliosis increases because of the setting in of restrictive lung disease, the patient could develop breathlessness on exertion.
Continue, please.
He has a mixed diet with normal sleep and appetite, with normal and regular bowel and bladder habits, and there was no history of substance abuse.
Coming to general physical examination, the patient appeared comfortably seated and was examined after taking a consent in a well-lit room. The patient was moderately built and nourished with a height of 165 centimeter and a weight of 60 kg with a BMI of 23.8 kg per meter square. The patient was conscious, cooperative, well-oriented to time, place, and person. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On vitals examination, the pulse rate was found to be 78 beats per minute, which was regular, normal in volume and character. All the peripheral pulses were felt. The blood pressure was recorded 120/70 millimeters of mercury in the right upper limb in sitting position. The respiratory rate was found to be 16 cycles per minute, which was regular abdominothoracic type. The peripheral saturation was found to be 98% with room air. The temperature was recorded to be 98.6 degree Fahrenheit. Bedside pulmonary function test. The Sabres single breath count test was found to be 40. Sabres breath holding time was found to be 36 seconds. Patient
How do you do this Sabres test? Please explain.
Sir, for the single breath count test, the patient is asked to take a deep inhalation. Patient is asked to breathe normally. Then he's asked to expire. Then while inhaling, he's asked to count from 1. We have to see how much the patient can count.
Okay, what is the normal this one count?
Sir, more than at least 25 minutes.
In breath holding, what is normal breath holding time? Sabres?
Sir, at least 25 seconds.
Continue. Yes.
Head-to-toe examination. There is no craniofacial deformity. The right shoulder appeared to be lower than the left shoulder. The convexity of the spine was towards the right. The scapula was prominent on the right side and it was lower. The gait was waddling. External genitalia were normal. Extremities were normal. There was no discoloration of the skin. Coming to airway examination, the mouth opening was found to be 3 fingers. There was no loose tooth or missing tooth. The entire incisor distance was found to be 6 centimeter. Patient had a modified Mallampati class 2. The neck movements of flexion, extension were adequate.
What is Mallampati grade 0?
Sir, epiglottis is visualized.
Yes. Continue, please.
The neck movements of flexion and extension were adequate. There were normal lateral movements. The thyromental distance was found to be more than 6.5 centimeter. Upper lip bite test grade 1. Temporomandibular joint, we were able to insunate finger. Sternomental distance was found to be 13 centimeter. Coming to systemic examination, respiratory system, the upper respiratory tract was found to be normal. The lower respiratory tract, the trachea appeared to be in the midline. Shape of the chest was symmetrical. The right shoulder was lower than the left. Right scapula was more prominent and lower. The chest movements were equal bilaterally in all the areas. There was no supraclavicular hollowing, infraclavicular flattening, or use of any accessory muscles of respiration. There was no dilated veins, scars, and sinuses.
What is trial? Trial sign.
Sir, trial sign, we used to see if there is any deviation of the trachea, sir. We place 3 fingers. The middle finger is placed on the surface of the trachea. The other 2 fingers are placed on the sternoclavicular joint. We try to insunate the finger on either side, and if there is feeling of resistance, it means the trachea is deviated to that side.
Continue. Next.
On palpation, all the inspectory findings were confirmed. The trachea is in the midline. There was no local rise of temperature or tenderness. The anteroposterior diameter was found to be 15 centimeter. Transverse diameter was found to be 35 centimeter with a chest expansion of 5 centimeter, which was equal bilaterally. Vocal phrenitis was normal in all the areas. On percussion, normal resonant note was found in all the areas. On auscultation, normal vesicular breath sounds were heard in all the areas. There were no added sounds and the vocal resonance was normal. Coming to cardiovascular system examination, on inspection, the JVP was jugular venous pressure was not raised. Apical impulse was not visible. There was no precordial bulge, no visible pulsations, sinuses or scars. On palpation, the inspectory findings were confirmed. The apical impulse was found to be in the left fifth intercostal space, half-inch medial to the mid-clavicular line. There was no thrill or parasternal heave. On auscultation, in all the 4 areas, S1 and S2 were heard and there were no murmurs. Coming to central nervous system examination, the higher mental functions were intact, cranial nerves were normal, motor system, the bulk of the muscles were normal, with a normal tone in all the 4 limbs, with a power of 5/5 in all the 4 limbs. The sensory system examination was normal. No, there were no signs of meningeal irritation, and the cerebellar functions were normal. Abdominal examination was unremarkable. Coming to the musculoskeletal system, the head was centered over the pelvis. The vertebrae were not perpendicular to the floor. The right shoulder was lower than the left. Left-sided scoliosis from the level of D7 to L3. There was no tuft of hair, swelling, or dimple in the midline. No high-arched foot. The Adams forward bend test showed that the deformity was present even on bending forward, which suggests that it was a structural anomaly and not a functional one. To summarize, an 18-year-old male presented with complaints of gradually progressive deformity of the trunk with dorsolumbar scoliosis with convexity to the right from D7 to L3 with preserved pulmonary function and no neurological deficits.
Okay. Based on your history and examination, how do you substantiate your diagnosis?
Sir, patient had a lateral curvature of the spine, which was present since adolescence. So it could be a case of idiopathic and there was no definitive cause which was found, sir. So it could be a case of adolescent idiopathic scoliosis. And since on examination, the bedside PFT appeared normal and the respiratory system grossly appeared normal. We can say that the patient had a preserved pulmonary function. And since the CNS examination was grossly normal, you can say patient did not have any neurological deficits.
Continue, please. What are the investigations you are going to do?
So we did the investigations we did were CBC, liver function test, renal function test, serum electrolytes, coagulation profile, serology, blood grouping and RH typing, and electrocardiography were the routine tests that we performed. His hemoglobin
Why do you want to do hemoglobin in scoliosis?
Sir, spine surgeries have increased chance. There is increased bleeding in spine surgeries, sir.
Okay.
So we need to know the hemoglobin so that we can calculate the maximum allowable blood loss and arrange for blood and blood products.
Continue, please.
And also, the spinal cord is prone to hypoperfusion, ischemia due to hypoperfusion, sir. So we need to keep blood and blood products ready.
Continue.
The special investigations that we ordered were a dorsolumbar X-ray, which was performed in the anterior, posterior, and lateral view, which showed a dorsolumbar levoscoliosis from the level of D7 to L3 with a corpse angle of around 50 degrees. There was also crowding of ribs, which was present on the left side. His lung parenchyma and cardiac silhouette appeared normal. His 2D echocardiogram showed a
How do you grade scoliosis?
So scoliosis can be graded based on corpse angle. If the angle is between 0 to 10, it's normal. If the angle is between 10 to 20, it's mild scoliosis. 20 to 40 degrees is moderate scoliosis, and more than 40 degrees, it's severe scoliosis.
Continue, please.
The spirometry was performed, which also showed a normal study.
Okay.
Our diagnosis was that an 18-year-old male with adolescent idiopathic dorsolumbar levoscoliosis with preserved pulmonary function and no neurological deficits posted for corrective surgery.
Okay. He is posted for corrective surgery, no? How do you prepare this patient for anesthesia?
So after a thorough pre-anesthetic evaluation, the patient was accepted for surgery under an American Society of Anesthesiologists Class 1.
Why it is ASA Class 1?
So he's a healthy adult with no comorbidities, with preserved respiratory function and no neurological deficits.
Continue.
With no history of substance abuse. We obtained a written informed consent from the patient, explaining to him about
Patient has got dyspnea, no?
Sir, but
Dyspnea.
yes, sir.
Yeah. Still, why you accept this case under ASA class 1?
Sir, because his bedside pulmonary function test as well as his spirometry and his respiratory examination were within normal limits, sir. Showed a normal
that is
state.
why. Yeah. Okay. Continue.
We explained to the patient about the anesthesia management, need for postoperative ventilation, blood transfusion, and the necessity to do a wake-up test was explained to the patient, and the patient was counseled regarding it. We also explained about the nil by mouth status for the patient. He was asked to remain nil by mouth for 6 hours for solids and 2 hours for liquids. Psychological and pharmacological anxiolysis was performed. He was asked to do deep breathing exercises and incentive spirometry. The surgeons were asked to reserve adequate blood and blood products, and they were also told about the need for postoperative mechanical ventilation. We prepared the OT by keeping ambient OT temperature. Emergency drugs were kept ready. Difficult airway cart was kept ready. General anesthesia drugs were loaded and kept ready. Infusion pumps, bolsters and eye padding, pipe lock, and equipment for neurologic monitoring were kept ready. We performed general anesthesia with endotracheal intubation, with reinforced tube with controlled mechanical ventilation, with intraoperative neurophysiological monitoring on this patient.
Okay. Why did you use reinforced tube? What are the advantages and disadvantages of reinforced tube?
So we use reinforced tube because the surgeons wanted a prone position, and they expected a long time for this duration of surgery. The advantages of using a reinforced tube is that there is limited kinking of the tube and dislodgement of the tube, sir.
What are the disadvantages?
So disadvantages are the secretions could get collected in the tube and it could cause increase in airway resistance and increased work of breathing.
Suctioning? It is a problematic. Suctioning.
Yes.
Difficult. Yeah. Okay. Next. Continue.
The patient was wheeled into the OR. IV access was gained. Standard monitors like electrocardiogram, pulse oximetry, non-invasive BP monitoring, end-tidal carbon dioxide, and temperature probes were attached. Patient was given injection glycopyrrolate at 0.01 mg per kg, injection midazolam at 0.02 mg per kg, injection dexmedetomidine at 1 microgram per kg, and under light sedation, arterial line was taken for invasive blood pressure monitoring, central venous cannulation was done, and electrodes for somatosensory evoked potential, motor evoked potential, and electromyography was placed. The frontal 4-lead montage for bispectral index was also placed. As you can see in this picture on the right side of the screen, the electrodes for motor evoked potential, sensory evoked potential, and electromyogram were placed, and the electrodes were wrapped to prevent dislodgement during positioning and during surgery, following which the patient was induced, and after intubation, the patient was put in prone position.
These are all the recording during?
These are the recordings we obtained at baseline.
Baseline and during screw placement, no?
During screw placement. The motor evoked potential and sensory evoked potentials were recorded throughout the surgery. The response for the motor evoked potentials were recorded at iliac muscle, psoas muscle, quadriceps, tibialis anterior, and abductor hallucis bilaterally. The abductor pollicis brevis muscle was monitored as a control. The stimulating electrode for motor evoked potential was placed at C3 and C4 and CZ and FPZ according to the 1020 international montage. All and compound motor action potentials were recorded, which showed adequate amplitudes and recurrent latencies throughout the surgery. For somatosensory evoked potentials, the the stimulating electrode was placed at posterior tibial nerve, and at the cortex, it was placed at the sensory cortex. SSCPs also showed adequate amplitudes with recurrent latencies throughout the surgery. These were the recordings obtained during derotation, compression, and distraction, and these were the recordings obtained during closure.
What was the surgery done here in this case?
Sir, it was the scoliosis repair surgery, sir, where there was multiple vasectomies were done, sir,
Multifacetectomy and
with the fixation, pedicle screw fixation.
okay, so less of retraction of spinal cord was encountered intraoperatively.
Okay, sir.
Considering there could be a retraction, you had kept all the monitors. Okay, please proceed.
Why do we need to do intraoperative neurophysiological monitoring for spine surgeries?
Sir, firstly, we need to reduce the neurological risk for the patient. In the post-operative period, the patient could have a post-operative loss of motor function, which can be due to the ischemia or a hematoma or manipulation, distraction or compression instrumentation of the spinal cord. So after 3 hours of critical ischemia, there is no neurological recovery. For the prevention and early recognition of these post-operative neurological deficits, we need intraoperative neurological monitoring. This enhances the patient safety. It also allows for interventions after detection of the potential risks. This also helps in minimizing the post-operative deficits. Also, sir, to improve the surgical accuracy, the surgeon uses while placement of pedicle screws, the surgeon makes use of intraoperative neurological monitoring, which we will see further.
Discuss further.
Okay. Next. Okay. Next. What are the principles of neurologic monitoring?
So there are 4 key principles of neurologic monitoring. The first principle being that the pathway at risk during during a surgical procedure must be amenable to monitoring. The second principle is that the monitor must reproduce reliable and reproducible data. Thirdly, an intervention must be possible if there is evidence of injury to the pathway. Fourthly, if there is no intervention which is possible, the monitoring is of prognostic value and may not be of benefit to the patient.
What are the techniques for neurological monitoring?
Neurological monitoring can be done either to assess the metabolic integrity of the nervous tissue, that is by assessing the global or regional blood flow or oxygenation. It can also be done to know the functional integrity of the central nervous system by assessing the global or the specific anatomical pathways, which includes the intraoperative neurophysiological monitoring.
What are the methods to assess the functional integrity?
Global functional integrity can be assessed using electroencephalography. The specific anatomic pathways can be assessed using evoked potentials and electromyography. Evoked potentials are of 2 types, sensory evoked potentials and motor evoked potentials. Sensory evoked potentials are again of 3 types, somatosensory evoked potentials, brainstem auditory evoked potentials, and visual evoked potentials.
What is evoked potential?
Evoked potentials, they record the electrical potentials which are produced after either a sensory or a motor tract is stimulated. These are plotted voltage against time. In this diagram, you can see that the evoked potential are recorded voltage against time. Here, the amplitude represents the measured signal voltage of a peak, which is relative to the baseline voltage. Latency is the measure that is the time interval between the application of a stimulus and the response which is recorded.
What is somatosensory evoked potential?
Somatosensory evoked potential is a method to assess a sensory pathway by stimulation of a peripheral nerve and looking for cortical response. An SSEP is produced by stimulation of the peripheral nerve, and the first order neurons from the peripheral nerve enters the dorsal nerve root and ascends the spinal cord via the dorsal column pathway. It synapses at the cervicomedullary junction and crosses the midline and ascends to the thalamus by means of the medial lemniscus. From here, the third order neurons relate to the sensory cortex. The sensory impulses from the upper limb are relayed to the parietal lobe, while the sensory inputs from the lower limb are relayed to the interhemispheric fissure.
Which are the nerves monitored during somatosensory evoked potential?
So for the upper limb, commonly monitored nerves are the median nerve and the ulnar nerve. For the lower limb, the posterior tibial nerve and the common peroneal nerve are commonly monitored, sir. The electrode placements for the upper limb, one electrode is placed at the stimulating nerve, one at the Erb's point, which is the point just above the middle of the clavicle, then at the cervical spine level, at the C2 level, and at the scalp of the contralateral parietal area. For the lower limbs, it is the electrodes are placed at the stimulating nerve, the popliteal fossa, the lower lumbar spine, the cervical spine, and the scalp. In our case,
What are some of the indications of somatosensory evoked potential?
The indications of somatosensory evoked potential include spine and spinal cord surgeries, brain and brainstem surgeries, cerebrovascular surgeries, thoracic and abdominal aortic aneurysm surgeries, brachial plexus surgeries, and carotid endarterectomy.
What are the limitations of somatosensory evoked potential?
so the dorsal columns are mainly supplied by the posterior spinal artery, whereas the anterior spinal artery will supply the motor tract. So any compromise in the anterior spinal artery may go unnoticed. Hence, we have to always supplement it with the motor evoked potential monitor.
What is brainstem auditory evoked potential and ABR?
Brainstem auditory evoked potential or auditory brain response is the second most widely used sensory evoked potential. It is generated in response to stimulation of the tympanic membrane by audible clicks. The stimulus intensity is set at 60 to 70 decibels above the patient's hearing threshold. It reflects the integrity of the eighth nerve and the brainstem. The indication for doing an auditory brain response include posterior cranial fossa surgeries. It is the most resistant sensory evoked potential to anesthetic drugs.
Which one is better, ABR, BAP?
Sir, it's the same, sir.
No. BAEP or ABR?
Sir, brainstem evoked potential is also known as auditory brain response.
Okay. Continue, please. What are the different waves in BAEP?
Sir, the waves which are the waveforms which are obtained in brainstem auditory evoked potential are 7, sir. But intraoperatively, we use one through 5 waveforms. If there is any loss of signal from 1 to 5 response, there are high chances that the patient will have postoperative hearing loss. The waveform 1 corresponds to the 8th nerve. Second one corresponds to the cochlear nucleus. Third one represents the superior olivary complex. The fourth one represents the lateral lemniscus. Fifth represents the inferior colliculus. Sixth represents the medial geniculate body, and the seventh represents the auditory radiation.
What is visual evoked potential?
Visual evoked potentials are sensory evoked potentials which are generated in response to monocular stimulation of the retina by flashes of light from light-emitting diodes. These are least commonly used sensory evoked potentials intraoperatively as they are highly variable. It can be used in optic nerve surgeries, orbital surgeries, and pituitary gland surgeries.
BAEP and ABR both are synonymous, but BAEP emphasizes the brainstem response to auditory stimuli, typically used in clinical settings to diagnose and monitor neurological disorders such as multiple sclerosis and brainstem lesions. Okay. ABR emphasizes the auditory pathway from the ear to the brainstem. Okay. Commonly used in audiology and otology to assess the hearing thresholds, auditory nerve function, and detect disorders. Example, acoustic neuroma.
Yes, sir.
What is MEP and where is it used? Motor evoked potential.
Motor evoked potentials, they are generated by the transcranial stimulation of the motor cortex, and recordings is obtained at various levels, that is along the spinal cord, peripheral nerve, or the innervated muscle. Often these are used along with the somatosensory evoked potential to assess the spinal cord function during spinal surgeries, aortic surgeries, infra and supratentorial surgeries.
What is the pathway of motor evoked potential?
The motor evoked potential is produced by the stimulation of the motor cortex. The electrical activity follows the cortical spinal tract to enter the anterior horn of the spinal cord. Next, it synapses to the peripheral nerve and traverses the neuromuscular junction, producing a muscle response, which can be recorded in the epidural space as D and I waves, or the muscle as compound muscle action potentials.
So what type of stimuli is given transcranially?
So transcranially, you can give both electric stimulation or a magnetic stimulation, sir.
It is commonly used practically.
Electric, sir.
Okay.
What are the differences between motor evoked potential and somatosensory evoked potential?
So the motor evoked potentials, they traverse the spinal cord in the anterior segment, whereas the somatosensory evoked potential will pass through the posterior part of the spinal cord. Injury in one area may not get reflected in the other area. So the somatosensory evoked potential include only white matter tracts, whereas the motor evoked potential includes both white and gray matter tracts. So the white matter is supplied anteriorly by the anterior spinal artery, and posteriorly the white matter is supplied by the posterior spinal artery. So there can be existence of a gray area, existence of a watershed area in the gray matter, which is more prone for ischemia. So the motor evoked potential is more useful in picking up these ischemic changes. Also, the somatosensory evoked potentials, their amplitude is very small and they need processing and summation. But the motor evoked potentials have a good amplitude. They do not need any processing.
What are the types of motor evoked potentials and techniques used for electrical stimulation?
So there are two types of motor evoked potential. It can be transcranial electric motor evoked potential or a transcranial magnetic motor evoked potential. And there are two techniques used for electrical.
The difference between big M and small m?
So the
Big M and small. Yeah.
So one is the
Capital,
small m
yeah.
stands for magnetic, sir. The big M is motor evoked potential.
Actually, muscle motor evoked potential. M.
No. Capital stands for magnetic, small for muscular.
Yes, sir.
Yes.
There are two techniques of electrical stimulation. One is a single pulse technique and the other is a high frequency train of impulses technique. In the single pulse technique, we use a high voltage of 100 to 400 volts, which is given for 50 to 500 microseconds. Whereas in high frequency train of impulses, we give a train of 5 to 7 impulses of 100 to 400 volts of high frequency of 500 hertz. In our case, we use a double burst technique, wherein first we gave a train of impulses to prime the motor tract, and and multiple D waves were recorded, which were to prime the motor tract. And the second stimulus was a single pulse stimulus which was given, and the response was recorded as compound muscle action potential at iliacus, psoas, tibialis anterior, abductor hallucis.
What are the other methods of priming the motor tract or a pyramidal tract? Apart from using a double burst.
So we can use two train of impulses, sir. Where the first train of impulse is for priming the motor tract, and the second train of impulses overcomes the effect of the anesthesia at the spinal cord level, sir. And these responses are obtained at the epidural level.
Okay. As D and I waves.
As D and I waves.
Yeah, we'll come to it later.
Yes, sir.
What do you understand about EMG?
Electromyogram is a recording of the electrical activity of the muscles which are innervated by cranial nerves or by the peripheral motor nerves. It can be active or passive. Active is when the nerve is stimulated and we watch for a response. Passive is when we record the spontaneous discharges from the nerve. The types of discharges includes popcorn. It can be a popcorn type of discharge. It can be response train or neurotonic discharge. Popcorn discharges is when the nerve, when there is simple contact with the nerve. The response train is seen when there is significant nerve irritation. The neurotonic discharges can be seen when there is nerve damage. Sir, in our case, a background electromyogram was running, but the surgeon did not ask for the discharges.
Electrified equipments are used to stimulate while pressing the transpedicular screw, but because this curvature was simple, it was not used in this case. Am I right?
Yes, sir.
Okay, please proceed.
Name few cranial and peripheral nerves which are commonly tested using electromyogram.
So we can monitor facial nerve, trigeminal nerve, spinal accessory nerve, and the hypoglossal nerve. These cranial nerves are commonly tested.
Yes.
The muscles at which they are monitored, orbicularis oris and oculi are monitored for facial nerve integrity, masseter or temporalis for trigeminal nerve, sternocleidomastoid and trapezius for spinal accessory nerve, and the genioglossus muscle for hypoglossal nerve. The peripheral nerves which are commonly monitored include the ulnar nerve and the common peroneal nerve. Abductor pollicis brevis and adductor digiti minimi are monitored for ulnar nerve integrity, while tibialis anterior and peroneus longus are monitored for common peroneal nerve integrity. We look for the integrity of the sacral nerve roots by looking for response at the anal sphincter. This is because of the bulbocavernosus reflex.
What are few indications for EMG?
The indications for electromyogram include posterior cranial fossa surgeries, parotid tumor surgeries, spinal surgeries during pedicle screw placement. In our case, the pedicle screws, this one is the areas where the pedicle screws were placed. It is also used for the excision of cranial nerve neuromas, brachial or lumbosacral plexus surgeries, and in neck surgeries.
Coming to this one, MCQ session.
Before coming to MCQs, I would like to
Yes, continue, please.
brief up on the types of neurological monitor used in your case. Can you do it personally, or shall I?
So we had somatosensory evopotential, motor evopotential, and electromyography. These were the neurophysiological monitors that we used in our case. We had a background of electromyogram running, but since there were no transpedicle screw fixation, which was done in our surgery, the surgeon did not ask for EMG, though we had a background of electromyogram running. But we recorded there were motor evoked potential and somatosensory evoked potential throughout the surgery.
Motor evoked potential was given intermittently. So I would like to brief up. I will brief up on your behalf. Motor evoked potentials were monitored throughout the procedure. The recorded muscles were bilateral muscles, iliac psoas, quadriceps, tibialis anterior, and abductor hallucis. That was the baseline. Abductor hallucis was serving as the baseline to check whether there is any loss of amplitude in the lower limb, because most of the segments operated here were lower upper thoracic and low upper lumbar. So the abductor pollicis brevis monitored as control. Okay. The stimulating site was the motor cortex. Placement was done by using, as you said, 10-20 system of montaging. And am I audible?
Yes, sir.
C3 and C4 areas, CZ, FZ, FPZ were also stimulated. All the compound muscle action potential, CMAP, what we call, showed adequate amplitudes and recurrent latencies throughout the procedure. And SSCPs were also monitored. The potentials were monitored throughout the procedure. Okay, the recording site was the somatosensory cortex according 10-20 system as per the electrode placement of international montage system. Stimulating site was the posterior tibial nerve. SSCP was showing adequate amplitude with the recurrent latencies throughout the surgery. This is how you have to brief up. EMG was running on the background, and the electrifying electrodes were given to the surgeon in case he wants to place the transpedicular screw. Okay, this is how you have to summarize.
Yes, sir.
Am I clear?
Yes, sir.
Please proceed.
MCQs. All the following are warning criteria regarding transcranial muscular muscle. Motor evoked potential during surgery, except which one is correct? Loss of response, increase in stimulus, stimulating threshold, single stimulus to trigger D wave at 100 volts, or change in the morphology of trigger response wave.
CG scan, please put up the answer in the chat box.
Yes. Which is the correct answer? All the following are warning criteria regarding, except.
I got one answer as D.
Correct answer is D. Change in the morphology of trigger response wave.
1 minute, sir. Answer is C. I'm sorry. I think it's C.
C.
Answer. C.
Answer?
C.
Okay. Single stimulus to trigger D wave.
But what is the correct answer? Single stimulus to trigger the D wave is at what voltage, Vaishnavi?
Sir, more than 200 volts.
Yeah, at least 200 to 400 volts. 100 volt is too less to stimulate a trigger of D wave. Okay.
Okay, next.
Okay.
See. Motor evoked potential is the standard intraoperative
Neurological
neuro
monitor.
monitoring in all these procedures except directly you can say which is the correct answer. Corrective axial skeletal procedures, surgery of neuroparenchymal disease, carotid endarterectomy, thoracoabdominal aneurysm surgery or intervention.
But Sneha, please proceed.
C answer, correct answer. Carotid endarterectomy. Yes.
Can you please elaborate?
Yes, directly. Next.
In carotid endarterectomy, we actually look for adequacy of cerebral blood flow and oxygenation.
Excellent.
Which is why we use monitors like electroencephalography and the somatosensory evoked potential. Motor evoked potential is not used for carotid endarterectomy, while it's used for all
much
the other
simpler method, much simpler neurological monitor. So that's why it is better.
Monitor for cerebral.
Okay, please proceed. Muscle motor evoked potential is monitored in the segmental muscle or a muscle group as D wave and I wave. Whether I'm right or wrong?
False. Wrong.
Yeah, Sneha, can you please elaborate?
Sir, it is false as at the muzzle level, we record a compound muzzle action potential. The D and I waves are recorded at the epidural space.
Very good, very good.
Okay. Anesthesia effects on MEP all are true except inhalational agents reduce amplitude. IV agents like benzodiazepines, etomidate, barbiturates, propofol, and dexmedetomidine can be used. Muscle relaxant interfere with the intraoperative neuromonitoring. Ketamine reduces the amplitude of compound
muscle action potential.
Muscle action potential. Reduces or increases? Which one increases? D.
Sir, the
it increases amplitude.
Yes, ketamine increases the amplitude of compound muscle action potential. Sometimes when the signaling, when there is loss of signaling or when there is some disturbance in the waveforms, then sometimes ketamine infusion can be used to amplify the muscle response.
The popular saying ketamine is a friend of neurophysiologist.
Yeah.
Okay. IV anesthetic agents, of course, at higher doses does interfere, but we have to use it. Inhalation is, of course, can never be used. Muscle relaxant have to be judiciously used.
Yes, sir.
Next. What are the anesthesia? Oh, only 4 questions now. What are the anesthesia considerations for intraoperative neuromonitoring during spinal surgeries?
So the anesthesia considerations for intraoperative neurological monitoring during spine surgeries involve the use of total intravenous anesthesia. We do not use muscle relaxants after the initial intubation and induction. We use soft bite block and we maintain a steady level of anesthesia. We need to maintain a blood pressure at mean arterial pressure more than 65 millimeters of mercury.
Why the use of TIVA in this case?
So the individual anesthetic agents, they have a tendency to cause changes in the sensory and the motor evoked potential, sir. That could be mistaken for surgically induced changes. As we can see in this table, the brainstem auditory evoked potentials, they are the most resistant to anesthetic agents. The visual evoked potentials, they are the most sensitive to anesthetic agents. Then agents such as etomidate, ketamine, opioids, and dexmedetomidine, they cause no or minimal changes in the sensory and motor evoked potentials. Propofol also causes minimal changes in the sensory and motor evoked potentials. Inhalational agents, when used at a higher MAC, more than 1 MAC, they cause significant changes in the evoked potentials, whereas they can be safely used less than 0.5 MAC where they cause minimal or no changes in the evoked potentials. In our case, for maintenance, we used since we did not use any inhalational agents. We used a propofol infusion at 100 mics per kg, and dexmedetomidine infusion at 0.5 mics per kg, with boluses of fentanyl.
Why did you not use neuromuscular blocking agents for maintenance?
As we previously discussed, sir, the pathway for motor evoked potential and electromyography traverses through the neuromuscular junction. So if we block the neuromuscular junction, we will not be able to elicit the response at the muscle level. And if the block at the neuromuscular junction is more than 75%, we will not be able to elicit a response at the muscle. So if at all, in order to obtain an adequate response, we did not use neuromuscular blocking agents during maintenance. If at all we use muscle relaxants, it should be we should monitor using a train of 4 response, and it should be maintained between 2 to 4 twitch count. That is below 75% block at the neuromuscular junction.
Suppose if you use neuromuscular blocking agents during
Sir,
maintenance,
we
you
should
can reverse with Sugammadex. You can reverse
Yes.
with Sugammadex, no? Now,
Yes,
Yes,
sir.
sir. We can.
no. What is the use of bite block?
Sir, in our case, the patient was maintained, the anesthesia was maintained without any neuromuscular blocking agents. Also, the transcranial motor evoked potential can cause contraction of the temporalis and the masseter muscle. Since we used total intravenous anesthesia without any inhalational agents, the chances that the patient was in the lighter plane was high. So if the patient is in a lighter plane, it can lead to tongue bite or biting of the tube, which may go unnoticed in the prone position. That's why we used bite block.
Why and how will you monitor the depth of anesthesia?
As you mentioned, there is an increased risk of intraoperative awareness in these patients. Intraoperative awareness could lead to postoperative cognitive dysfunction. It also leads to increased stressor response in the intraoperative period. In order to avoid this, we need to monitor the depth of anesthesia. There are multiple modalities available to monitor the depth of anesthesia. It includes electroencephalogram, bispectral index, patient status index, narcotrend, entropy, A-line autoregressive index, and cerebral state index. In our case, we use bispectral index, and we maintain it between 40 to 60 by titrating the propofol and dexmedetomidine infusion and giving boluses of fentanyl. Bispectral index is a type of processed EEG where 4 parameters are considered and a single number is given ranging from 0 to 100. It usually corresponds to the cortical activity and the depth of anesthesia. In case we are using drugs like ketamine, dexmedetomidine, or nitrous oxide, bispectral index will not correspond to the depth of anesthesia. It does not correspond to accurately with the depth of anesthesia even in pediatric patients.
What is EEG?
Sir, electroencephalogram is a surface recording of the summation of the excitatory and inhibitory post-synaptic potentials, which are generated by the pyramidal cells in the cortical gray matter, sir. It can be, it is usually cortical, and there is very less information about the subcortical functioning. In this diagram, we can see it is the international 10-20 montage. That is the placement of the electrodes of EEG. It is placed in between 4 bony prominences, that is the nasion, inion, and the 2 temporomandibular joints. The electrodes are placed, are labeled such that the left-sided electrodes are given an odd number and the right-sided electrodes are given an even number, and the central electrodes are represented by a Z. The electrodes correspond to the area in which they are present, that is frontal, temporal, parietal, and occipitals.
What are the different waves seen in EEG?
So there are four waves which are commonly seen in EEG. The first is a beta wave between 12 to 30 hertz, which is seen in awake patients. And alpha waves, which is between 8 to 12 hertz, which is seen in an awake patient with their eyes closed, or in lighter planes of anesthesia at the time of induction. Theta waves and delta waves are low frequency waves with higher amplitude. Theta waves are from 4 to 8 hertz, and delta waves are from 1 to 3 hertz. These are seen in deep sleep or in deeper planes of anesthesia. EEG can be activated with when the patient is asked to focus on a particular task like problem solving, wherein we can see gamma waves, which is beyond 30 hertz. And EEG can be activated during epilepsy, where epileptiform spikes are seen. And in ischemia, there is a gradual decrease in frequency, and in severe ischemia, even the amplitude reduces.
What are the effects of anesthesia on EEG?
Sir, when we give sub-anesthetic doses initially, either through intravenous route or inhalational route, there is increase in the beta frontal activity and the abolishment of the alpha activity in the occipital leads. Then as we deepen the plane of anesthesia, as the patient loses their consciousness, the wave's amplitude will increase, whereas the frequency will start to decrease. That is, there is shift from alpha activity from posterior cortex to the anterior cortex. Finally, it will lead to burst suppression and eventually an isoelectric EEG. The drugs which do not cause burst suppression are ketamine, dexmedetomidine, then opioids and benzodiazepines. Drugs which cause burst suppression are inhalational agents and IV induction agents such as propofol, thiopentone, which are when given in high doses.
Hypnotics and inhalation agents. Okay.
What are the uses of electroencephalogram?
As we know, the cerebral blood flow in an adult resting brain is 45 to 55 milliliters per 100 gram of brain tissue per minute. We see abnormalities in the EEG when the cerebral blood flow reduces to 20 ml per 100 gram of brain tissue per minute, and an isoelectric electroencephalogram is seen when the cerebral blood flow is reduced to 15 ml per 100 grams of brain tissue per minute. It is also used to guide anesthetic-induced reduction in cerebral metabolism, either in anticipation of loss of cerebral blood flow or treatment of raised ICP. We also use electroencephalogram to predict the neurological outcome after brain insult and to monitor the depth of anesthesia. The other uses of electroencephalogram include identification of consciousness, unconsciousness, or seizure activity, stages of sleep or coma.
What are limitations of EEG?
So the electrode encephalogram, we have to place multiple electrodes, and expertise is needed for reading or interpretation of the intraoperative changes in the EEG. Thus, we can use a processed electroencephalogram where the raw EEG signals are digitally processed and they are displayed for easy interpretation. The most available processed EEGs used by anesthesiologists, they have 4 channels or less, whereas the EEG which is used for regular recording, that is the raw EEG, has 16 channels or 16 channels. EEG is typically, it is based on the analysis of a raw segment. The processed EEG is based on analysis of a segment of raw EEG, which is known as epoch. This epoch undergoes a Fourier analysis to give a processed EEG. This processed EEG is applied for depth of anesthesia monitoring, such as bispectral index, narcotrend, entropy, patient safety index, etc.
Why do you want to maintain mean arterial pressure more than 65 millimeters of mercury?
So we need to maintain a arterial pressure of more than 65 millimeters of mercury to prevent spinal cord ischemia secondary to hypertension. As I previously mentioned, the posterior 1/3 of the spinal cord is supplied by 2 posterior spinal arteries, whereas the anterior part of the anterior 2/3 of the spinal cord is supplied by a single anterior spinal artery. From the levels of T6 to L3, we have the artery of Adam-Kiewicz, which is a radicular artery which also supplies the anterior part of the spinal cord. There are 3 This leads to a watershed area in 3 regions, which can be seen at the levels of T4 to T6, sometimes in the lumbosacral area, and sometimes at the level of T8 to T9. These watershed areas are more prone to ischemia due to hypoperfusion. In order to prevent injury to these regions, we need to maintain a higher MAP. We also need to maintain a higher mean arterial pressure to maintain the cerebral blood flow within the autoregulatory range.
What is considered as a significant in intraoperative neuromonitoring?
Sir, with respect to somatosensory evoked potentials, the changes are considered to be significant when there is decrease in the amplitude by more than 50%, or when there is increase in latency by more than 10%. Whereas for motor evoked potentials, they're considered to be significant when there is decrease in amplitude by more than 70%, or when there is absence of the motor evoked potential, or when there is increase in the stimulation threshold, or when there is failure of the signal amplitude to return to baseline. When there are when we find significant changes in the waveforms, then it is the time to intervene.
How will you manage a intraoperative neuromonitor alert?
So whenever there is an intraoperative or a significant change in the potential recorded, evoked potential responses recorded, we need to start intervening. This can be done by the surgeon, anesthesiologist, and the neurophysiologist. The surgeon is asked to stop the current manipulation, to release traction, to check for compression of the dura, and to reverse any corrective maneuvers which were performed, to confirm the stability of the spine, and to look for implant malposition, to achieve hemostasis, and to apply warm saline wound wash. We check if there was any bolus of anesthesia drug which was given, or if muscle relaxants were given, and we need to lighten the depth of anesthesia. If you're using a volatile agent, we need to reduce the minimum alveolar concentration, or we need to discontinue the inhalational agents used. We also need to reduce the background IV anesthetic infusion which we're using. Otherwise, we can also add an adjuvant like ketamine because it increases the amplitude of the evoked potential. We need to target a higher mean arterial pressure of more than 90 millimeters of mercury. We need to maintain adequate oxygenation, avoid tachycardia, make sure that we have we are supplementing the blood loss with adequate volume. We maintain a normal pH and temperature and monitor adequate urine output. We also need to check if the limb positions is positioned properly. The neurophysiologist is asked to repeat the trials of evoked potential or to increase the strength stimulus. We ask them to check if there are any technical faults or if any dislodgement of the electrodes or if it's incorrectly placed. And we ask them to assess the pattern of changes in the evoked potential. In spite of all this intervention by these 3 teams, we assume that there is an irreversible neuronal damage which has occurred, and we go ahead with increasing the mean arterial pressure more than 100 millimeters of mercury. We consider administration of steroids or calcium channel blockers either topically or intravenously. We consider waking up the patient and performing a wake-up test, or we can consider aborting the surgery.
I would like to say irreversible neurological damage is around serious type of neurological ongoing that has occurred on table. It can be reversed also. Okay. Yes, so that should come at the end. If no improvement, you increase the BP to more than 100 millimeters of mercury, consider steroid, or consider even that CCB topical IV. And 2 more things you have mentioned at the bottom of the slide.
Yes.
Okay.
What is Stagnara wake-up test?
Sir, this is of historic importance. Stagnara wake-up test was done to monitor the loss of motor function intraoperatively. Nowadays, it is being replaced by motor evoked potentials. Stagnara wake-up test is still done in case the motor evoked potentials show a reading which cannot be interpreted, or if there is loss of signal of the evoked potentials, then finally we can go for a Stagnara wake-up test. The patient is pre-operatively, they're sensitized and they're counseled about this test. It is essentially, we lighten the plane of anesthesia. by discontinuing the anesthetic agents or keeping very low doses of anesthetic agents, and by reversing the neuromuscular blockade. Then the patient is woken up and the motor function is assessed by asking them to move the limbs or clenching the fist of the anesthesiologist. And after the test is done and the results are obtained, the patient is re-anesthetized. The problems which are associated with this test are it can lead to accidental extubation, tube biting, increased stress response in the patient. It does not provide a continuous information. It provides information only at that point.
Stagner-Evoked test is a clinical neurological monitor. In few of the instances, this has saved the patient. When the complete loss of signal, no matter whatever maneuver you have tried, there is no signal, again resuming signal. In that case, Stagner-Evoked test was done and it was favorable and the surgery was continued and the patient had no neurological deficits. This has been documented also.
Other than scoliosis correction surgery, which other surgeries will you use neuromonitoring?
So we can use neuromonitoring for carotid endarterectomies, where we do electroencephalography, somatosensory evoked potential, transcranial Doppler, and cerebral oximetry to look for adequacy of cerebral blood flow and oxygenation. In surgeries for acoustic neuroma, we monitor the facial nerve and brainstem auditory evoked potential to look for the integrity of the facial nerve. In surgeries for intracranial aneurysm clipping, we monitor somatosensory evoked potential, electroencephalogram, and transcranial motor evoked potential. For cranial nerve 5 decompression, we monitor the brainstem auditory evoked potential, and for cranial nerve 7 decompression, we monitor brainstem auditory evoked potential and facial nerve monitor by EMG for integrity of the facial nerve. For supratentorial mass lesions, for spinal cord trauma, for decompression of spinal stenosis, and for aortic aneurysm surgeries, we monitor somatosensory evoked potentials along with transcranial motor evoked potentials to monitor both the sensory and the motor pathways. In cardiopulmonary bypass, we monitor electroencephalogram, transcranial Doppler, jugular venous oximetry, and cerebral oximetry to look for adequacy of cerebral blood flow and oxygenation during the bypass.
How do you assess the metabolic integrity of nervous system?
So the global metabolic integrity of the nervous system is assessed using transcranial Doppler ultrasonography, jugular bulb oximetry, cerebral oximetry. The regional determinants include cerebral microdialysis, brain tissue partial pressure oxygen tension measurement, and thermal diffusion cerebral blood flow monitoring.
For global determinants, as I previously mentioned, we do the transcranial Doppler ultrasonography, where we monitor the blood flow velocity, which is normally between 35 to 90 centimeters per second. In case of cerebral vasospasm, it is more than 120 centimeters per second, which is measured in the middle cerebral artery. We also monitor the pulsatility index and indices of autoregulation. The advantages of using a transcranial Doppler ultrasonography is that it is non-invasive. It can be used intermittently or continuously. It has good temporal resolution, and it can be used for the identification of emboli. The disadvantages of using transcranial Doppler ultrasonography is that it measures relative cerebral blood flow. It is operator dependent, and there could be a loss of acoustic window in 5 to 10% of patients. For jugular venous oximetry, we monitor jugular venous oxygen saturation, which is normally between 55 to 75%. If it reduces below 55%, it indicates that there is an increased oxygen demand or a decreased oxygen supply. If it is more than 75%, it indicates hyperemia or a decreased cerebral metabolic rate, which can be seen in severe ischemia. It also measures the arteriovenous oxygen gradient. The advantages of jugular venous oximetry is that it is a global assessment of the balance between cerebral blood flow and metabolism. It is limited by the fact that it is a non-assessment of cerebral perfusion. It is insensitive to regional ischemia, and it can be contaminated by extracranial contamination of the samples can happen when we draw more than 2 ml at a time. Cerebral oximetry or near-infrared spectrometry. In this, we monitor the regional cerebral oxygen saturation, which is normally between 60 to 75%. It is non-invasive and gives us real-time multi-site measurements. The disadvantages of cerebral oximetry is that there is a lack of standardization between commercial oximeters, and there could be contamination of the signals by extracerebral tissue, and the ischemic threshold for cerebral oximetry is not defined.
Yeah. Next.
Coming to the local determinants, we have the brain tissue partial pressure oxygen measurement. Here, the brain tissue partial pressure is measured. Normally, it is between 20 to 35 millimeters of mercury. The advantage is that the regional assessment of balance between cerebral blood flow and the metabolism can be monitored continuously. The ischemic threshold is defined between 10 to 15 millimeters of mercury. Disadvantage is that it is minimally invasive. It measures the oxygenation within a region, a small region of interest, and 1 hour run-in period limits. These limit the intraoperative application. The next one is the thermal diffusion flowmetry, which measures the regional cerebral blood flow. It measures the absolute cerebral blood flow in ml per 100 gram tissue per minute. Limited clinical, the disadvantage is that it has a limited clinical experience and it is minimally invasive. The next one is the cerebral microdialysis, where we measure the monitored variables are glucose, lactate pyruvate ratio, glycerol, glutamate, and other biomarkers. The advantages are that the assessment, it can be used for the assessment of glucose metabolism, detection of hypoxia, ischemia, and the assessment of non-ischemic causes of cellular dysfunction. Disadvantage is that it is a focal measure. The thresholds for abnormality are not clear. It is not continuous and it is labor intensive.
What are the non-surgical applications of neurologic monitoring?
Neurologic monitoring can be applied in the intensive care unit, emergency department, and neurocritical care departments. It can be used for monitoring and prevention of secondary brain injury due to traumatic brain injury, secondary to aneurysmal subarachnoid hemorrhage, or CVE. Continuous EEG monitoring can be done in these patients, and it may be beneficial in comatose patients for the diagnosis and timely intervention of non-convulsive seizures or regional ischemia due to vasospasm after subarachnoid hemorrhage, and to prognosticate patients in coma and for determination of brain death.
Are there any other parameters that can affect intraoperative neuromonitoring other than anesthetic agents?
Yes, sir. Hypothermia, hyperthermia, hypoxia, hemodilution, hypocarbia, and hypoglycemia. All these cause changes in the somatosensory sensory evoked potentials, whereas dyselectrolytemia like hypocalcemia can cause changes in the motor evoked potentials. Hypothermia causes increase in the latency and a decrease in the amplitude. Hyperthermia causes decrease in the latency. Hypoxia, hemodilution causes changes similar to ischemic changes. That is, there is decrease in the amplitude and increase in the latency. Hypoglycemia and hypocarbia causes decrease in the latency.
What are some of the recent advances in neuromonitoring?
So the recent advances in neuromonitoring include multimodal neuromonitoring, especially for traumatic brain injury patients, wherein we use automated pupillometry, continuous monitoring of electroencephalogram or evoked potential, non-invasive means of measuring intracranial pressure, brain tissue oxygen pressure, cerebral microdialysis, transcranial ultrasound, transcranial Doppler ultrasound, and brain optic nerve sheet diameter. We also have biomarkers like S100B, neuron-specific enolase, tau proteins, glial fibrillary acidic proteins, ubiquitin C-terminal hydrolase L1, matrix metallopeptidase 9, and cerebral microdilysate products, including glucose, lactate pyruvate ratio, glycerol, and glutamate. All these are released by cells specifically in the CNS, like the neurons, astrocytes, and glial cells. Therefore, these are highly predictive of neuronal injury.
Coming to MCQ session.
Shall I summarize something?
Last after MCQs, we will summarize. Okay. Next. All the following are essential monitors in reconstructive major spine surgeries except cortical, somatosensory, evoked potential, tissue, partial pressure oxygen, EMG, EEG.
So, sir, please keep the slides for little longer time, huh?
Okay.
Okay, madam. Okay, I will
Because
keep.
the topic is little complicated.
Okay. All the following are essential monitors in reconstructive major spine surgeries except cortical, somatosensory, evoked potential, tissue, partial pressure oxygen, EMG, EEG. You can guess. The correct answer is B, tissue, partial pressure oxygen. Next. All are true about EMG except sensitive test to detect radiculopathy. Cutting of nerves results in loss of EMG responses. EMG is normally inactive under anesthesia. EMG is useful in monitoring cranial nerve function during brain surgeries.
Apparently, all of the options look true.
No. One is except one.
One of them, yeah, that's why. Vaishnavi will elaborate it later.
Sir, I think we'll just wait for some time. PGs can just attempt to answer the question.
Yeah, let them answer, madam. No problem.
Please answer. Even if it is wrong, they can answer. Yeah, there is one answer. Anybody else, please put in answers in the chat box. Don't worry, even if it is wrong. Think and answer. Yeah.
EMG is useful in monitoring cranial nerve function during brain surgery.
Yeah.
That is?
I think maximum have got the answer correct, sir. It's A.
Okay. Vaishnavi, please elaborate. Dr. Vaishnavi, please elaborate.
The answer is actually
Apparently, all the options appear to be
No.
true.
For cranial nerve function, no?
Yeah.
Yes,
Please continue.
Sir, it has been found that the facial nerve is the only cranial nerve, which gives exact results. The other cranial nerves have not been found to be monitored intraoperatively. Even if they were monitored, there are high chances of false negatives, sir, and false positive. That's why it is not preferred.
Facial nerve is monitored in which surgery?
Sir, in Pontine surgeries, posterior cranial fossa.
CP angle tumor. CP angle tumor.
Yes.
Yeah, good. Very good.
Next slide, please. What is the critical ischemic period for spine? 1 hour, 2 hours, 3 hours, 4 hours. 1 hour, 2 hours, 3 hours, 4 hours. Correct answer is 3 hours. Next slide, please. Which drugs potentiate somatosensory evoked potential response? Ketamine, etomidate, both, none.
Yeah, here there are many answers coming up.
Yeah. Yes,
We'll
madam.
wait for some time, sir.
Okay, madam. We will wait, madam. No problem.
SSCP response, not MEP response.
Somatosensory evoked potential.
Yeah. Because most of them are answering.
There is a mixed response, sir. C, A.
Yeah. Almost A, B, C.
Yeah.
But appropriate answer is C, both ketamine as well as etomidate.
SSCP.
A also correct, B also correct, C. Correct answer is C. So far we discussed with this one advantages and uses of this neuro monitoring. What are all the complications of neuro monitoring?
So neuromonitoring itself can cause epilepsy, seizures during transcranial stimulation.
Very
It can
good.
also cause injury to the patient. There could be increased intraoperative awareness leading to postoperative cognitive dysfunction, infection. As these are invasive, it could also lead to bleeding. And also there's a lot of contamination which could happen, sir, as these electrodes have to be invasively placed.
Sometimes a panic warning sign also can be activated.
Yes,
As
sir.
you said, it could be a panic, but actually nothing has occurred.
Yes, sir.
Complete loss of signal amplitude can occur because of the displaced leads. Okay. So that's the reason why Stagnara wake-up test also has to be explained to the patient pre-operatively.
Yes, sir.
I'd like to summarize, regardless
Okay,
of
please.
sir,
Please go on.
regardless of the type of the intraoperative neurological monitor, we have to go with the several principles, as Dr. Snehal has already pointed out. Several principles must be observed for neurological monitor to provide the potential benefit to the patient. First and foremost is the pathway at risk during the surgical procedure must be amenable to monitor. And secondly, if the evidence of injury to the pathway is detected, some intervention must be possible. And if the changes in the neurological monitor is detected or are detected and no intervention is possible, although the monitor may be of prognostication value, it does not have any potential providing potential benefit to the patient. And early detection of impending neurological injury. Thirdly, the monitor must provide reliable and reproducible data. If the data has a very high degree of variability in the absence of clinical interventions, the utility for detecting the clinically significant events is limited. So overall, I would like to summarize, a lot of randomized controlled prospective studies are lacking in this field. And finally, some of the procedures, the monitoring should be done for selectively patients believed to be at higher risk than the usual risk for intraoperative neurological injury.
NIMAS Neuroanesthesia Department, they have come up with their own guidelines regarding this neurological monitoring. Okay, they have developed their own guidelines, and also they have developed newer generation monitoring system. I think Dr. Raghunandan sir, if he is there, he can enlighten us regarding this latest guidelines and also newer generation monitoring system, because he has put in this chat box.
Yeah. Dr. Raghunandan.
Please unmute him.
And also he has shared some of the videos to Dr. Madhuri madam.
Yes. So I think he'll speak after the class, after some time.
Okay,
We'll
madam.
ask him. We'll ask him to speak, sir.
Okay, madam.
Yeah. Meanwhile, just look into the questions in the chat box.
No questions, madam. Nothing. Almost.
Dr. Wajiha,
Yes, ma'am.
just coordinate. Check if there are any questions, if anybody's raised the hands.
Till now, ma'am, no questions.
No questions, madam. Difficult topic, no, that is why.
Very difficult topic, but you have really understood the topic so well yourself. And it was a challenge to take up this topic basically and explain it so well in very simple language. And the PGs are really very lucky, sir.
Thank you, madam. Thank you.
In fact, this case had got postponed many times. Finally, it came to
3 times it was postponed.
We were not interested in doing that case. But ultimately, we found
That case was done in private hospital, madam, not in this one government hospital. Private.
Okay. Okay. So anybody wants to ask any questions? Okay. Ma, can I just
Somebody is asking about the recording, na?
Yes,
So
sir. Recording and
will be,
also
yeah,
videos.
it is at YouTube at ISNHQ. You can always go for the recording. It's always available there. No problem about that. So in the meanwhile, what we have to do is we have to felicitate our faculty. Just wait for 1 minute. My screen visible?
Yes, sir.
Yes, sir. Visible, sir. Yes, sir.
Yeah. So Srinivas sir, thank you very much for taking up this
Yes.
challenging class and preparing your team well for this very important class and session. And it will be now as a permanent property of the ISA, recorded on the YouTube. Everybody can see and take advantage of during their examination. So thank you very much, sir, for being the team leader in this class.
Thank you, sir. Thank you.
Then Dr. Vivek, you are equally, I think, contributed to the preparation for this class with the PGs. And I know the next moderator is always working very hard. So
Yes.
equal thanks to you also for being a moderator in this class.
That was a teamwork, sir. Thank you so much, sir.
Yeah. And Vaishnavi, yourself and Sneha. So your confidence was emanating in every answer you were giving today. So good. So you have really lived up to your expectation and showed the hard work put in by the teachers. So that is very, very important. So your teaching is good. I think you have cleared the pre-final. So now prepare for your final in the January.
Yes, sir.
And Dr. Vijaya, she is there with, in spite of the celebration of Eid going at her place, she wasn't in the class. So thank you, Dr. Vijaya, for being with us as a screen coordinator.
Thank you.
And Dr. Ishita also, she also did very well as a screen coordinator. This is the technical things going on, and it brings the a smoothness to the class conduct. And more importantly, I thanks Dr. Madhuri, Dr. Ridhima, and Dr. Nishant for being the class coordinator for a long time with me, and that's very important. This is how the classes go in a smooth manner. And I think anybody wants to give a suggestion or any the particular question they can ask at the moment.
So there's one question in the chat box.
Yeah.
What are the medical legal liability in a scene of practice? These patients came from low income class. We don't have these facilities.
Yeah, I will answer that because in the beginning I told, see, the neuro monitoring has advanced. It doesn't mean that with the advancements of the monitoring techniques or something that every setup will also advance. Because you have to give treatment to every nook and corner of the country. We are in a living in a resource limited nation, and with the manpower and equipment and gadgets. It's a basic neuro monitoring is always the clinical parameters whenever you are doing in the periphery, whatever the monitors you have, the basic monitors, that comes your clinical acumen, how you monitor those things. But it is always advisable if the surgery is a very, very, aggressive surgery where the neuro monitoring is required and you don't have the facilities at the peripheries or at the smaller hospitals, it is always advisable to refer these patients to a center where the justice can be done to their surgical procedures rather than taking the glory on us with the limited things which can be easily prevented. Provided the emergency situations, sometimes if it's not able to transfer the patient or we are not in a condition to transport the such patient, in such scenarios, you have to develop on your clinical acumen, your clinical knowledge, your skill experience. So neuro monitoring, actually, it's monitoring standards have been, very well conducted in the advanced centers only. In our setups, in our country, not in our country, in many Asian countries, African countries, we don't have that much of a setup in the periphery. So that question will always remain in the minds of everyone, how we go about it. Rely upon your, even keeping a hand on the pulse, a finger on the pulse, if you ask anesthesiologist of 40 years earlier, they can tell you how the nervous system also behaves. So these things are very important. How you correlate your entire medicine, how you correlate your entire knowledge about every system, how the inter-system is interrelated, the nervous system with the cardiac, with the respiratory. So that is the basics of a neuro monitoring. Rest, I think advanced monitoring always helps, but you can't give a certain answer that every neuro monitorings that in the periphery we should not undertake those operations. Those have to be taken. The load is very much on every center. You can't refer every patient to a higher nerve center, but definitely
Yes, sir.
those patients which require aggressive monitoring, they should be referred to the centers where those things are available. That's my take on this in the present scenario. May not be advocated by the going by the evidence-based medicine or by the legal things also sometimes. But this is how our scenario is at present in our country. I further Dr. Srinivas sir to develop on anything different to that also if you can.
No.
Dr. Srinivas.
Yes, sir.
Anybody has to add to this, they can add to that. Dr. Madhuri, you want to add?
Yeah, the thing is that nowadays we have so many trauma centers all over the country, and we have spine surgeries taking place almost everywhere. So neuro monitoring has become very important.
That's true. That's what I'm saying.
Yeah.
In the advanced centers, it's a label now. In the advanced center, the government is also funding, even the private sector also. They have those gadgets at many centers where these advanced surgeries are being done. But I can assure you at many hospitals in the country, spine surgeries are being done in the spinal also, in the lower,
Yes, sir.
the
Yes, sir.
lumbar,
Yes.
lumbar
In our
spinal
institute
surgeries
only,
are done in the spinal. And then I think in some GA also. But I don't think so. Monitors are available in every hospital, even in a bigger hospital also. You may not be getting. I think that's where the fight of anesthesiologists is going on to get the best of the equipment for those surgeries. So it's a balance of so many things. Very difficult to, as administrator also sitting at the helm of the society. It's difficult for us to plan the policies till the government comes out with certain helplines or certain policies at the center where you can make this equipment available to almost every center in a subsidized manner or something. Otherwise, this is a huge game. Pharma companies also or equipment companies also.
Acha, one question for Dr. Sneha and Dr. Vaishnavi. So this
Gold
is a
medal
little
question.
bit no. This is a little bit like what is the relation between body mass index and this neurophysiological monitoring? How does it affect? Like you mentioned several factors, na? Like hypothermia and so many other factors which can neuromuscular blockers which can affect the monitoring. What about body mass index? How is this important in, yeah, tell.
There can be reduction in the amplitude of the waveforms.
Excellent. Which ones?
Somatosensory and
Transcranial motor evoked potential, especially. Yeah. So especially in obese people, this is very much indicated, this neurophysiological monitoring intra-op. Why? Because there is chances of injury to the
Inadvertent injury.
nerves, especially because in obese patients. So it is very much warranted. You have to use. Okay. And coming to one just a bit offbeat, like we had a last class on temperature monitoring, and this time we have a neuro monitoring. So how is temperature monitoring important in this case?
We have to maintain an ambient OT temperature, ma'am, because hypothermia can cause a decrease in the amplitude and increase in the latency of the waves. And
Yeah.
hyperthermia also is the deleterious. It can cause increase in the latency.
Yes. And inevitably hypothermia will occur because they are very long duration surgeries, spine surgeries. Anything else?
See, I will like to ask one thing here before I forget, because I missed certain part of the class. I was somewhere. So Sneha and Vaishnavi, do you think that doing the wake up test is a good thing nowadays with so much of the advanced monitoring there? Is a wake up test required?
Sir, we do not do a wake-up test unless there is a significant IONM alert which is there, sir. And in spite of the interventions that we do, if there is no improvement, then we go ahead and consider wake-up test as one of the interventions, sir. Otherwise, we try to monitor the neurological pathways with SACP and MEP only, sir.
Last
Why I asked this question is the wake-up test, it goes a little bit crude on the patient. In the present day scenario where we are talking about advancements and still resorting to the traditional methods of the wake-up test. And is it crude on the, because always aware, once we had awareness under anesthesia, those things are also taken into account, and legal purpose, legal matter also on this type of things. Na?
Yes.
So this was my question only, very small. You may not need to answer that, but that is important. I wanted your views as a PG student, whether you would like to go some relatives of yours is getting operated, and the experience may be very horrific for the patient. If you don't know how much awake the patient can get, how much awake, the degree to what, or maybe is feeling so paralyzed with so much of impending doom, and so many feelings are there in vary from patient to patient. So I think the advancements of neuromonitoring is such that it's a boon that we have to do away with the wake-up test also.
Yeah, and one more thing, Dr. Sneha, continuing with the temperature, what about hypothermia?
Ma'am, hypothermia also decreases the amplitude of evoked.
No, but is it important that you have to detect hypothermia in these cases? Hyper.
Yes, ma'am.
Is it important to look
Yes,
for
ma'am.
hypothermia?
Yes, ma'am.
Since we are stimulating the muscles, ma'am, there can be high chances of rhabdomyolysis.
That is rhabdomyolysis. But how will it produce hypothermia? Your patient was a case of scoliosis, right?
Scoliosis, they
I
can
gave
be
you the hint.
associated with muscular dystrophy.
Yes. So there are high chances of malignant hypothermia. So we had discussion in last class, and nowadays lot of discussion going on malignant hypothermia, as Sir said. So it's important to do temperature monitoring. Good. Very good, sir. Excellent.
Thank you, madam. Thank you.
Excellent preparation. Now you have to give sweets from Mysore to all the PGs who answered your difficult
definitely.
question.
Mysore Pak. Mysore Pak.
Okay, madam.
I think we should end this class now.
Yes, sir.
It's a wonderful
Thank you,
class,
sir.
sir.
Thank you, sir.
Most.
Thank you. Thank you, sir.
Thank you.
And, good night to everyone.